Hi, hello, can you hear me? Is everybody there? Right? Hmm? Salam, sir. Walaikum assalam. Thank you. Yeah, okay. Right. I hope you're doing fine. And अब तो आप लोगों की शक्लें भी भूल गई होंगी मेरा ख्याल है, पता नहीं 3 महीने से हो गए हैं घर बैठे हुए। हाँ? Right. Okay. Okay. I think we got limited time. तो कोई गपशप भी साथ में बाद में करेंगे. We'll have a little bit of chat. तो अभी तक जो है, I think I'll talk about. We did about acute pancreatitis, and Dr. Hassan also took you along gallbladder problems initially. इसमें एक ही टॉपिक जो है वो रह गया है, that is carcinoma of the head of the pancreas, right? Now, the neoplasm of pancreas, I think, should start with that. For every organ, they can have a benign lesion, benign neoplasms, and a malignant one. Okay, for pancreas, the same is true. That you have benign pancreatic neoplasms. Walaikum salam, everybody. Now, the benign pancreatic neoplasms include benign adenomas, benign cystadenomas, and as you know, pancreas has endocrine as well as exocrine functions. So the islet cell tumors as well, like Zollinger-Ellison syndrome, usually they are benign but can be malignant. Zollinger-Ellison syndrome, as you know, is like gastrinomas. And you also have beta islet cell tumors like insulinoma and alpha cell tumors like leukogenoma. So these are all benign pancreatic neoplasms. They're not very common. They are usually about 2% of the pancreatic tumors. But the most important tumor when they talk of carcinoma of the pancreas, it is usually ductal adenocarcinoma, arises from the pancreatic duct. Okay, so remember that. When they talk of pancreatic neoplasm, they usually mean malignant neoplasm. Now, as you know, the pancreas has head, body, and tail. So most of these malignant neoplasms are in the head. That is 60% of the carcinoma of the pancreas means that's carcinoma of the head of the pancreas. And this is surgically very, very important, as well as the prognosis, which is usually very poor. It's a bad news if you come across somebody having a pancreatic neoplasm, because it usually presents late. As you all know, neoplasm of these pancreas itself is a deep-seated gland, and they usually present late. I'll tell you the different presentations of the carcinoma of the pancreas, but mostly ductal adenocarcinoma is of head. And out of this 60% carcinoma of the head, you can have periampullary carcinoma. That's also included in the head. That is the around the duodenal papilla and around that area. It is about 25% of the carcinoma of the head of the pancreas, periampullary carcinoma. And it is important that to know that they present a little bit early than the rest of the carcinoma of the pancreas, because it blocks the uh, the duct, blocks the papilla, and patient presents with jaundice early. So that's one of the things, and they usually present as a painless jaundice. It's very important to remember, if the patient has a painless jaundice, they just present to you with a jaundice and no pain. The important thing is painful jaundice. That is due to gallstones. If the gallstone moves into the CBD, they cause obstructive jaundice. That's a painful jaundice because the movement's the gallstone. But in carcinoma of the head of pancreas, it's a painless jaundice. Patient suddenly feels that it's jaundice, and he says there's no pain. That's very sinister presentation of carcinoma of the head of pancreas. Okay, so the next one. Now, what are the risk factors? Who develops pancreatic cancer? Usually, they are elderly people, 65 to 75 years of age. Uh, Majority are male, and they say the black ethnicity is not only COVID that is more common in black and Asian people. It is said that even the carcinoma of the pancreas also more common in the black ethnicity. Okay, those who are cigarette smokers, well, they tend to have more. Then, of course, there are genetic factors and other medical conditions which are associated with this incidence of the pancreatic cancer. Now, the family history, if there's a positive family history, there is a chance that the patient might develop pancreatic cancer. If the two first-degree relatives with pancreas cancer, the relative risk increases from 18 to 57 folds. So it's a quite strong genetic predisposition. Now, the other thing is BRCA2. You might have heard BRCA1 and BRCA2 genes in breast cancer. Similarly, BRCA2 mutation in some areas in the pancreas gland can give rise to a pancreatic cancer and in high risk families as well. Then hereditary pancreatitis. Some people have hereditary pancreatitis. There's no gallstones or any other possible source. It's just hereditary. And that is 50 to 70% fold increased risk of developing pancreatic cancer. Some people do get history of chronic pancreatitis. That is also a factor, risk factor for development of pancreatic cancer. There is another condition called Lynch syndrome. It's non-polyposis colonic cancer associated with pancreatic cancer. Okay? Lynch syndrome. Then ataxia telangiectasia, Pitts-Jagger syndrome. They're all associations, genetic factors, and other medical conditions which can be associated with pancreatic cancer. Familial breast ovarian cancer syndrome can have a part as a pancreatic cancer. Then familial atypical multiple mole melanomas can be associated. This familial adenomatous polyposis, risk of ampullary or duodenal cancer, long-term diabetes mellitus can be incriminated as a risk factor for the development of the pancreatic tumor. Okay? So these are the risk factors. Basically, the elderly people, no definite kind of reason why people suddenly present with painless progressive jaundice, okay, in case of pancreatic. The lesson to take home is painless progressive jaundice in an elderly person. Always think of pancreatic cancer. And it's a bad news because it's got very bad prognosis. Okay, hardly anybody survives more than 5 years once the diagnosis is made. So it's a bad prognosis disease, bad news. Now, how do they present? That's very important for you people to remember. As I mentioned, this patient, elderly person, presents to you, you look into his sclera, the eye, and you see this patient looks jaundiced and is painless. Sometimes they do complain of some dull pain in the upper abdomen and also to the back because pancreas is retroperitoneum. In acute pancreatitis, as you remember, patients do get back pain in addition to epigastric pain. But they do in acute pancreatitis, they have high amylase. In this case, patients have uh, dull pain in the upper abdomen and or just the pain in the back. They got painless progressive jaundice with this dull pain. Some people presents with diabetes because of the involvement of the islets of Langerhans beta cells. Some people develop with presents with the thrombophlebitis migrans, nothing else, just thrombophlebitis. That is different veins of different legs, different arms. They're getting inflamed veins, and you uh, do a CT scan, and you see that there's a carcinoma of the pancreas. So it's very odd kind of presentations as well. It's called Trozier sign. You get thrombophlebitis migrans, and you look for a CA pancreas. It's called Trozier sign. Then, of course, the general features of malignant disease. Patient may present to you with ये मुझे समझ नहीं आ रही वजन कम होता जा रहा है भूख भी नहीं लगती and I get nausea. So an elderly person, now you should have always in your mind that this patient might have a carcinoma maybe of a pancreas gland. So these are the main clinical presentations. Painless progressive jaundice, usually asymptomatic, may have dull pain, sometimes with diabetes, sometimes they have thrombophlebitis migrans, or sometimes nothing at all of these kinds, but just the weight loss. So that's why it's a disease which presents late. Okay, very rarely you see a mass in the epigastric region presents as a carcinoma of the pancreas gland. Okay, now the important thing to remember now, you remember this whenever it comes to pancreas, carcinoma of the head of the pancreas, is called Courvoisier's law. Now, the Courvoisier's law, as you all know, uh, or you must know, if a patient presents you with a painless progressive jaundice and you examine the right hypochondrium and you feel that the gallbladder is distended, there's no pain, patient is jaundiced, with the gallbladder is distended, then this is almost always due to carcinoma of the head of the pancreas. So why do you develop this? Because the carcinoma of the head of pancreas, it presses from outside the common bile duct. The common bile duct is dilated and the bile goes back and stored into the gallbladder. Gallbladder gets distended. Now it's jaundice because the carcinoma of the head of pancreas and a distended gallbladder. If the patient presents like this, that means it is most likely due to carcinoma of the head of pancreas. More than 50%. There are some exceptions to this rule that sometimes there's a CBD stone and there's also stone in the cystic duct. The CBD stone causes jaundice and cystic duct stone blocks the cystic duct and the gallbladder can be distended. So, but for Courvoisier, if somebody asks you Courvoisier's law, that means In a jaundiced patient, painless jaundice, if gallbladder is palpably enlarged, it is almost always due to carcinoma of the head of the pancreas. I hope you understand that. Okay? Do you understand that? Yes? Right? Write down yes if you do understand. If you don't understand, I can repeat it because it is very important. One of the presentations of carcinoma of the head of pancreas is there is a mass distended gallbladder in the right hypochondrium, which is non-tender, and the patient is jaundiced. That means it's a carcinoma of the head of the pancreas. Okay, good. Right. Okay, now, as I mentioned, you carcinoma of the head of pancreas, 25% of the cases are, now this is a post-mortem specimen of periampullary carcinoma. This is the ampulla. This is the second part of the duodenum, which has been resected. The first part, the second part of duodenum, the third part, and the fourth part. So that's the carcinoma, periampullary carcinoma. This is counted as a carcinoma of the head of the pancreas. Now, this specimen is pancreaticoduodenectomy. You remove the head of the pancreas, you remove the whole of the duodenum. It is called pancreaticoduodenectomy, or the specimen, and the operation is called Whipple's operation. Sometimes they ask you, what is Whipple's operation? That means you do pancreaticoduodenectomy. Actomy means removal of the head of the pancreas along with the duodenum. Okay, so resection. Okay, so that's the periampullary carcinoma. That's the resection. All right. Next is when you do an endoscope and you go to the second part of the duodenum, you can actually see this periampullary carcinoma. That's the ampulla of the waiter. That is the pancreatic duct opening here into the second part of the duodenum, and around that papilla, around that ampulla, you can see this is a carcinoma. Now, when you do, that's why endoscopy is important, that you see this lesion and you take a biopsy, you can confirm that that's a carcinoma, and you can do pancreaticoduodenectomy. The prognosis of a tumor of periampullary is much better than carcinoma of the head of the pancreas, which is the rest of the head of the pancreas. This is about 15 to 25% cases of carcinoma of the head of the pancreas. Now, if you do endoscopic ultrasound, EUS, endoscopic ultrasound scan, see that's the inside, and that's the periampullary tumor, right? Okay, so that's the endoscopic view, and that's the endoscopic ultrasound, giving you a view of periampullary carcinoma. Now, how you do that? The Whipple's operation, surgery.
Which device did
Now,
you plug in?
imagine that's the whole pancreas gland, and there's a tumor here,
Line in.
pancreas. बातें आवाज आ रही किसकी आ रही हाँ कैसी हो ठीक हो So this is called the Whipple operation, all right? Now the carcinoma of the head of the pancreas, you leave the body and the tail there because you need pancreatic secretions, the exocrine secretions especially, and the endocrine secretion in body and tail. So you remove that carcinoma of the head of the pancreas. That is the cure, trying to cure the disease, okay? It's a curative attempt at curative resection. You're trying to cure the patient of carcinoma of the head of pancreas by doing a Whipple's operation, okay? called pancreaticoduodenectomy. You remove the head of the pancreas. Imagine it's right in front of the aorta and the inferior vena cava. Okay, so you got to be very, very careful. Okay, get all the branches ligated and remove that along with the duodenum, because it's just stuck with the duodenum. So you can't just leave there. Okay, so you have to remove the head of the pancreas, you have to remove the duodenum. Now, once you remove that, now the CBD is coming through the head and opening into this. So you have, look at this, the common bile duct. You have to divide it at the top. Divide the common bile duct. Now you got common bile duct here, you got the pancreatic duct here, and once you removed it, the duodenum, so you got the stomach here. So the pylorus is there, okay? Pylorus is there. So you got the pylorus, you want food to go into the intestine. You want the bile to go into the jejunum. So what you do, bring a loop once you've done pancreaticoduodenectomy. Now listen carefully. Whipple's operation is pancreaticoduodenectomy, removal of the head of the pancreas along with the duodenum. Okay, once that is taken off, now you bring a jejunum loop, bring it up. Now do choledochojejunostomy. Okay, the bile duct with the jejunum. So that problem is solved. Bile will be collected here into this. Now that pancreatic duct, you make pancreaticojejunostomy. Okay, you do that anastomosis, and the third is gastrojejunostomy. Okay, so you got the food which is collected into the jejunum, you got the pancreatic juice collected into the jejunum, you got the bile draining it. So all these things, after removal of pancreas and the duodenum, you got all these enzymes collected into the jejunum, and that helps in digestion. So that is attempt at curing the disease. But most of the time when it presents, it's very late, it's very difficult, it's either attached to the spermomesenteric vessels or to these great vessels, and it's very difficult to remove the whole tumor. So you went up doing palliative surgery. That means just to relieve the symptoms and not actually trying to remove the whole tumor along with the duodenum. Okay, so that's the triple kind of Roux loop. It's called Roux loop, ROUXLOOP, Roux loop of jejunum. You bring a Roux loop of jejunum and do these three anastomoses here: choledochojejunostomy, pancreaticojejunostomy, gastrojejunostomy. Okay, it's called Y loop. So if you look at that, that's the one limb, that's the other limb, that's the other limb. Okay, so Y loop of jejunum to do all these three anastomoses. If somebody asks you what is Whipple's operation, well, you do pancreaticojejunostomy, sir, pancreaticoduodenectomy, sir. You remove the head of the pancreas and the duodenum, and you do choledochojejunostomy, you do pancreaticojejunostomy, and do gastrojejunostomy. Okay, so that is Whipple's operation. Unfortunately, even after curative resection, right, there's hardly any 5-year survival. Okay, nobody lives for 5 years. It's very, very poor. And most of the time, even after this resection, People die within 2 years, 3 years. Okay, so that's why it's got a bad news if you say that somebody has got carcinoma of the pancreas gland. That's why the surgery is the only mainstay. If you don't do it, you don't do anything, do just palliation. People live for 9 months or a year with all these symptoms of jaundice, itching, pain, and nothing be able to eat because the, the pancreas gland presses onto the duodenum. Nothing goes beyond the duodenum. Whatever you eat will stay there. Patient will be vomiting, right? Okay, so this is Whipple's operation. There's two important messages to take, two terms to take home. One is Courvoisier's law, that in the jaundice patient, gallbladder is palpably enlarged. That means it's due to carcinoma of the head of pancreas, and Whipple's operation. Courvoisier's law and Whipple's operation. The important two things to remember, two terms that are used in surgery. Okay, and these are very favorite to surgeons. Now, the next picture. Now, sometime there's a tumor there. Carcinoma of the head of pancreas is pressing on to the common bile duct. And what palliation can you do? Palliation means you're not doing a Whipple's operation. Patient's cancer is advanced, and you want to alleviate the jaundice. I mean, you don't want the patient to be jaundiced. You want to do something with it. So what you can do is, with an endoscope, you go down to this papilla, pass a guide wire through the CBD, and pass this metallic stent. Okay, it's called metallic mesh stent in the bile duct, so that the bile from the liver can come and drain into this, so you relieve the jaundice. So this is the palliative procedure. It's not a curative. You're not going to cure the disease. You're not going to cure the tumor, but you can get rid of the jaundice of the patient. Okay, and the patient jaundice is relieved. Patient is feeling much better. There's no jaundice now. So that's one palliation. Now the other thing is, now that tumor gone bigger and pressing onto the duodenum. Now whatever you eat, nothing goes down. So what you left with, what you do, pass an endoscope and pass a metallic stent into the duodenum. So first the metallic stent into the CBD to relieve the jaundice. Now you want the patient to eat or at least drink some fluids. Try to pass this stent into the duodenum. It's called duodenal stent, metallic duodenal stent. So it stays in shape, so whatever you eat or drink, it passes through. And the effects of pressure of the pancreatic tumor. So these are all palliation. You're not removing it, because you can't remove it as it is inoperable. You can't operate on it. It's all stuck with all great vessels and everything. So this is palliation. Sometimes they ask, what are the palliative procedures you have to do or you have in mind in case of carcinoma of the head of pancreas? You can say it's the pass a metallic stent in the CBD, stenting of a CBD to relieve the jaundice, stenting of the duodenum to relieve the dysphagia. Patient can't eat anything, so you can pass that. If you can't pass that stent, what you can do is bring a loop of jejunum and join it with the stomach. It's called gastrojejunostomy. So food directly from the stomach goes into the jejunum. It doesn't have to go through that. You can do gastrojejunostomy. Okay? There are two ways of doing gastrojejunostomy. The anticolic in front of the transverse colon, anticolic gastrojejunostomy in front of the transverse colon or behind the transverse colon, retrocolic, bring the loop of jejunum behind the transverse colon and anastomose with the stomach. So that's gastrojejunoscopy. That's another palliative procedure. Okay. So stenting the CBD and stenting the duodenum. These are the palliative measures. Okay. To relieve the jaundice and ask the patient been able to eat something. Now, what are the other palliative treatment? Because patient is jaundice, so what you do is you treat the biliary sepsis, you put a biliary bypass. Now, how you can do biliary bypass? All right, let's go back. Bring if the CBD is obstructed by the tumor, you can also do bring a loop of jejunum and anastomose with choledochojejunostomy. All right, or you can pass a catheter, a stent from the skin through the liver into this. This is called percutaneous transhepatic cholangiopancreatic PTC. PTC, percutaneous. You can pass that to relieve the jaundice. If nothing is working, pass a, a, a catheter percutaneously into the liver through these radicals, and you can drain the jaundice. You can drain the bile outside. Okay, that's also one thing. All right, so that's what it is. PTC. You can do ERCP stent in the CBD, PTC, or you can improve the gastric emptying either by duodenal stent, or you can do gastro and jejunostomy or gastroenterostomy, as I mentioned to you, to bypass this pancreatic tumor. Now, these patients do get severe pain in the back in advanced condition. Now, what you can do is you escalate the analgesia, give them opioids if they're a lot of pain. You can block the celiac plexus. Okay, you can inject the celiac plexus to block it, so the patient don't feel any pain. And sometimes you can do transthoracic splenectomy. So transthoracic is like an injection. You can do that. Now, symptom relief and quality of life can also be if you encourage normal activities, you replace the enzymes for steatoria because there are no lipase or anything going into the system, so you can replace them. Okay, if the patient is diabetic, you can treat the diabetes by giving them insulin, and sometimes there is some place of chemotherapy, but not of great value. Sometimes gemcitabine and some radiotherapy can also give some palliative relief. So, what are the palliative procedures for a pancreatic cancer? When you cannot remove the tumor, you relieve the jaundice by some kind of a bypass, biliary bypass, or stenting by doing ERCP or PTC. You improve the gastric emptying by doing gastroenterostomy or pass a duodenal stent. That is to relieve the jaundice and to relieve the dysphagia. Pain relief is another thing. How you can do that, give them opioid, block the celiac plexus, or transthoracic splenectomy. Okay, then encourage normal activities, treat steatoria, treat diabetes, and consider gemcitabine. That is the chemotherapy, usually drug used, pancreatic cancer, and sometimes radiotherapy as well. Okay. Now that you should know about the pancreatic cancer that presents late, and you do this examine it, Lavoisier's law, then you got Whipple's resection, procedure, pancreatic duodenectomy, and the palliation of pancreatic tumor. Usually the questions from this. But now combining all these areas together, gallbladder, acute pancreatitis, pancreatic CA. Now the question usually comes in UHS, in your final examination. I'm going to have some questions in front of you. What kind of questions they ask regarding gallbladder, regarding acute pancreatitis, regarding pancreatic cancer. Usually there are 2 or 3 questions from this area only. So I'm going to give you samples of these questions, okay? Now, case 1. Now the question will be like this. 46-year-old female, she gives a 4 hours history of right upper quadrant pain after a fatty meal. You know, female, 40, fatty, and radiating the right scapula, and patient is pain-free now. Okay, she had a pain initially, but now she's pain-free. No previous episode. You examine the patient Murphy's sign, that is the tenderness during inspiration in the right hypochondrium. Murphy's sign. Now that is negative. Okay. The white cell count is normal. The normal white cell count is between 4 to 11. You should know all the normal values because they sometimes just mention these. You should remember them. Okay. White cell count 8. That is within the normal range, 4 to 11. So the LFTs are normal. You do a right upper quadrant ultrasound that reveals gallstones, cholelithiasis. And there is no gallbladder wall thickening. There is no pericholecystic fluid. Pericholecystic fluid means because of inflammation, you get some fluid around the gallbladder. Pericholecystic fluid. Okay? We say, what is the diagnosis? Now, this patient, normal white cell count, there is no infection. There is no minimal tenderness or no tenderness. Murphy's is negative, but the patient has got gallstones. So what was the diagnosis? Why the patient had pain? What is the diagnosis? The diagnosis is patient has a biliary colic. The diagnosis is biliary colic, pain due to gallstone, but it is not causing any infection. It is not acute cholecystitis. Because if you have acute cholecystitis, there'll be Murphy sign positive, white cell count will be raised, okay? There'll be some edema around the gallbladder, the fluid around the gallbladder, pericholecystic fluid on ultrasound, okay? So these are the distinguishing features. If you don't have any of these, but you just have pain and the gallstones, the diagnosis is biliary colic. Don't write down acute cholecystitis because I'll give you the example. Okay, sorry about that. Where am I? First, go to this. Now, the same case, 46-year-old lady, the same patient. Now she had the previous patient had just no previous attacks, but this patient had multiple previous attacks of right upper quadrant pain. इसको काफी देर से बार-बार upper quadrant pain में below the right ribs pain होती थी, लेकिन उसको फीवर भी नहीं है, वाइट सेल काउंट भी नॉर्मल है, अल्ट्रासाउंड में गॉलस्टोन भी हैं, गॉल ब्लैडर थिक वॉल भी है, लेकिन अक्यूट पेरिकोलिसिस्टिक फ्लूइड नहीं है, बार बार होते रहे हैं, ठीक है, गॉल ब्लैडर बार बार इन्फेक्शन होने की वजह से थिक वॉल्ड हो गया है, तो दिस इज chronic cholecystitis. It's not acute, it's chronic cholecystitis, multiple prior attacks of similar pains. Now उसको fever है, now उसको white cell count raised है. It's not acute cholecystitis, it's chronic cholecystitis. So the diagnosis is chronic cholecystitis. Okay. Sometimes they just ask you this question. Now, another scenario. Now, the same patient, history of 24 hours right upper quadrant pain, radiating to the right scapula, started after fatty meal, and associated with nausea, vomiting, fever. Now, there's some infection going on, is fever. Now, the Murphy sign is positive as well. And because the gallbladder is palpable and tender, there's some guarding as well. It's called Murphy's sign. It's inspiratory arrest. You ask the patient to take a deep breath and push the right upper quadrant. During inspiration, the patient will catch a breath. Suddenly, oof. So white cell count is raised as well. As I told you, the normal white cell count is between 4 and 11. Now this white cell count is 13. That means there is some fever. There is a raised white cell count. Okay, and positive Murphy sign. That means the gallbladder is inflamed. When you push it in the right upper quadrant, it will be tender. There is acute inflammation. Ultrasound shows gallstones. There is some pericholecystic fluid. There is some Murphy's positive sign, very specific. On the ultrasound probe, you push it and the patient will have pain. Okay, this is called sonography. एक तो आप clinically करते हैं ना हाथों से with your right hand in the right hypochondrium. Now, the sonologist, the radiologist, is using a probe to confirm that the Murphy's sign is positive. It's called sonographic Murphy's positive. Okay, it's very specific. And they can say that this is acute cholecystitis. Now the diagnosis will change now. It's not biliary colic, it's not chronic cholecystitis, it's acute cholecystitis, right? Okay. So that's the difference. Acute cholecystitis will show raised white cell count. Murphy's sign will be positive. There'll be pericholecystic fluid on the ultrasound scan. And there'll be gallbladder wall will be slightly distended. Now, next scenario, I think we've got to go a bit quicker. We just nearing the last 15 minutes. Now, this is slightly different now. Now, 87-year-old male who's critically ill because of some conditions. Maybe he's got uremia, he's got renal failure, he's got diabetes, he's got hypertension, he's in ICU, he's on long-term total parenteral nutrition, and now suddenly has right upper quadrant pain. Very important, pay some attention now. Now, elderly person is very ill because of some other conditions, but suddenly developed this right upper quadrant pain, white cell count is raised, he develops some fever. But when you do an ultrasound scan, there are no gallstones. There's no acute cholecystitis. It's not stone causing the problem. What is the diagnosis? Why this gallbladder is so much painful and pericholecystic fluid? Why the gallbladder is inflamed without any gallstones? This is the diagnosis in critically ill patient. There's a condition called acalculous cholecystitis. Acalculous cholecystitis means absent of gallstone. In critically ill elderly people who are in intensive care, they can develop acute cholecystitis and is acalculous without any gallstones. Okay? So remember these scenarios. Okay. Now the next scenario is another different thing. Now, 46-year-old female, right upper quadrant pain, history. She's jaundiced. She got pale stools. She's jaundiced, pale stool, and dark tea-colored urine. Dark urine, but there's no fever. She has a history of cholelithiasis. That means one of the stones from the gallbladder has passed from the gallbladder through the cystic duct into the common bile duct and has blocked it. This is called obstructive jaundice. Pale stools, no bile is going down the intestine because the stone has blocked the CBD, and no bile is going into the duodenum, so there's no color of bile in the stools. It's called pale stools and dark colored urine. The whole of the bile is getting absorbed into the blood and filtering through the kidneys into the urine. So dark colored urine, pale stool, jaundice, history of stones, obstructive jaundice. Okay? It's called obstructive jaundice. Mind you, this white cell count will be normal. Bilirubin is high. Okay, right. You know, the bilirubin, 8. 8 is quite high. Usually is around 1 to, if you get sort of 1 to 2. If you get high bilirubin, that means it's jaundice. Alanine transferase and aspartate transferase, their normal levels, BC are negative, hepatitis BC negative, ultrasound shows gallstone and shows CBD stone and dilated CBD. Normal diameter of CBD is up to 7 to 8 millimeter. Okay, it is beyond 8 millimeter, that is 1 centimeter, that 10 millimeter. Okay, if the CBD is dilated, there's a stone in the CBD, patient is jaundice, pale stool, dark color urine, obstructive jaundice. What is the diagnosis? Obstructive jaundice. Okay? I hope you understand that. Right. The next scenario. Okay. Now you should know what is Charcot Stride. Female, fever, right upper quadrant pain, and jaundice. 3 things: fever, pain, jaundice. Called Charcot Stride. 3 things together. Now, this lady also had some altered mental status. She's not feeling well, and there are signs of shock. There is tachycardia, there's some kind of infection, and blood pressure is going down. You've done the ABCs of resuscitation. You give them fluids, antibiotics, everything, large bore cannulas, IV fluid, continuous monitoring, IV bolus, repeat until resuscitated. What is the diagnosis? Charcot Stride. Patient is in near shock, tachycardia, hypertension, jaundice patient. Cholangitis. Patient is developing high temperature, jaundice, fever. Okay? And you have to resuscitate. Patient is tachycardic, hypotensive. It's all called because of septicemia. It's cholangitis. Okay? Infection from the biliary sepsis due to obstruction of CBD, causing jaundice, fever, and right upper quadrant pain, Charcot Stride. So the diagnosis would be biliary sepsis, cholangitis. Now, the last thing, or a couple more. Now, it's case number 7. The same lady, 46, pain in the epigastrium. Now, look at this, back pain. Now this thing came in. Epigastric pain, back pain. She's known to have gallstones. She's not alcoholic. She's got tender epigastrium. Amylase is 2000. The normal amylase is up to 100 or 150. This is 2000. Raised amylasemia, that is pancreatitis. And because it's due to gallstones, it's called gallstone pancreatitis. The diagnosis would be gallstone pancreatitis. Okay, good. That's another scenario. They can ask you, give a history of pain going to the back. So when they say going to the back and raised amylase, pancreatitis. And they're also giving you a hint that the ethanol means no alcoholic use. Okay, so that is gallstone is the offending agent that's caused pancreatitis, gallstone pancreatitis. All right. Now remember Cavoy's law. 67-year-old male presents with painless progressive jaundice and palpable non-tender gallbladder. No persistent progressive jaundice, painless progressive jaundice, elderly male, and a palpable gallbladder. Is Cavoy's law. Diagnosis, carcinoma of the head of the pancreas. Okay? So that is Cavoy's law. So now I'm going to remind you these things. Cavoy's law, Whipple's operation, that is pancreatical duodenectomy, and triple anastomosis. Now this is another case of then Charcot's triad. Okay, three things: fever, jaundice, pain. Okay, that is biliary sepsis. Right, what's the time now? We've got 5 minutes. I'll leave that for some questions, all right? Any questions? I hope it was helpful. Any question? Yes? Okay, I'll wait for if there's any question. So we're nearly covering this gallbladder, pancreas, acute pancreatitis, as well as CA Head of Pancreas. We covered the upper GI. I think maybe we'll move on to the other lectures doing small bowel and large bowel, and all these diseases related to small bowel, especially the obstruction and tumors. That's pretty common in special surgery, appendicitis, then you got Crohn's disease and ulcerative colitis, inflammatory bowel disease, carcinoma of the rectum, carcinoma sigmoid, colonic cancer, then bleeding PR as an emergency. So these are the important things. Any questions so far? Okay. No question? Right.